Hi all, I'm Scott Bragg, clinical pharmacist and assistant professor. I prepared a presentation on how to manage medications in patients with Alzheimer's disease or dementia. To preface this presentation, do know current medication treatment options are limited and the focus should be on taking medications away. The objectives for this talk will be to discuss dementia medication management options, identify appropriate factors to work up prior to diagnosing dementia, and stop harmful medications in the elderly. If there are things not covered in this presentation, please feel free to email me. Unfortunately, Alzheimer's disease is increasing in incidence as the population ages. By age 85, it is expected that 50% of the population has some form of dementia. Currently, no therapy or treatment has shown to stop the progression of cognitive decline. Dementia is characterized by a decline in level of functioning, impaired ability to function at usual activities, detection and diagnosis of cognitive impairment, and two of the following criteria: impaired recall of new information, reasoning, visual spatial skills, language function, or changes in behavior. The diagnosis of Alzheimer's disease should not be made if the onset of dementia occurs after a stroke, another disease where medication affects cognitive abilities, or there are features of Lewy body disease, frontotemporal dementia, or primary progressive aphasia. Prior to making the diagnosis, make sure an extensive workup is performed. Several important reversible conditions to rule out are depression, delirium, uncontrolled seizures, infections like neurosyphilis or HIV, alcohol abuse, obstructive sleep apnea, and vitamin B12 and folic acid deficiency. Imaging is recommended by the American College of Radiology for workup of any structural abnormalities. The ACR criteria recommend a non-contrast head MRI as the most appropriate test. The best form of imaging may change as new imaging is validated to better diagnose different forms of dementia. When assessing cognitive function, use a validated scale and scores over time. Be cautious with the mini mental status exam as it is a copyrighted exam and should be paid for. A few free, well-validated exams exist, like the Montreal Cognitive Assessment, or screens like the Mini-Cog or the Verbal Fluency Test. After diagnosing dementia, by excluding other causes of memory impairment, patients and caregivers need to know symptoms will progress and few things we do slow that decline. Reorienting patients, providing reassurance, and doing activities the patient likes are some of our best therapies. Two classes of Alzheimer's disease medications exist. Aricept, Exelon, and Razidine are acetylcholinesterase inhibitors. They come in various forms: tablets, solution, patches, and oral disintegrating tablets. Namenda is an NMDA receptor antagonist that comes as a solution or tablet. All medication options are modestly effective for improving cognitive outcomes and may slow observed decline in cognition. However, much of the evidence focuses on disease-oriented outcomes like improved cognitive scores. They do not prevent the inevitable decline in cognitive function, so caution caregivers that remarkable benefits are unlikely to be seen. All dementia medications are titrated up over 4 to 6 weeks. Try choosing a medication based on presumed patient compliance with a particular regimen and cost. Common side effects with both medication classes are insomnia, nausea, vomiting, diarrhea, infections like flu, dizziness, headache, and hyper or hypotension. Many patients are not taken off of therapy after an appropriate trial. Wait 6 months to assess the benefits of dementia medications. If no benefits are noted, taper the medication off. To taper off, decrease the dose over 4 to 6 weeks to ease caregiver concerns over a rapidly worsening cognition. Watch out for medications that can impair cognitive function. Mechanistically, acetylcholinesterase inhibitors are increasing synaptic acetylcholine concentrations. Use of medications with anticholinergic properties will thus impair cognitive function and dementia medication effectiveness. When using medications with anticholinergic properties, make sure they are absolutely necessary, use the lowest dose possible, and pick agents with lower possibility of side effects. Try to avoid antihistamines, urinary incontinence meds, TCAs, anti-nausea meds, benzodiazepines, pain medications, corticosteroids, and antipsychotics. So how should we use antipsychotics in patients with Alzheimer's disease or dementia? Analysis from 17 placebo-controlled trials have shown a 1.6 to 1.7 higher likelihood of death. These results prompted a black box warning for antipsychotics in patients with dementia. Deaths are thought to be related to an increase in stroke, CHF, sudden cardiac death, and pneumonia. Advise not to use the antipsychotics in the elderly unless using it for someone with active hallucinations or in severe agitation where patients remain a danger to themselves or others. When assessing medications in the elderly, make sure medications are clearly indicated and weigh their risk and benefits. Prescribing in the elderly can be challenging, so when making changes, slowly titrate a medication up or taper a medication down, and only make one change at a time. In general, using non-pharmacologic measures are most helpful when treating Alzheimer's disease. Orienting caregivers to community resources remain some of our most effective interventions. Many resources are available through the Alzheimer's Association website at www.alz.org. After reviewing this video, I hope that you can discuss dementia medication management options, identify appropriate factors to work up prior to diagnosing dementia, and stop harmful medications in the elderly. Thank you for your attention, and please email me if you have any questions.